How's it going, guys? So this is a pass level question for USMLE Step 1 and Step 2. Not hard, not complicated, but not every question I do has to be overly dramatic. I will tell you some important factoids, not waste our fucking time. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram at Mehlman_medical, MEHLMAN_medical. The link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's hop into the actual question here. 29-year-old man, 1 month history of fatigue. He's lost 5 pounds during this time. Vitals are normal. Serum studies are as follows. Now look, you'll have the normal ranges available to you on the labs on the exam. You have to take your fucking training wheels off. These are hyper basic. Okay, you're gonna be a doctor. Learn your fucking lab values. Stop crying. So your potassium should be 3.5 to 5. It's elevated here at 5.5. You've got a sodium that's low at 133. Should be 135 to 145. Bicarb is low at 21, should be 22 to 28. So this combo, okay, of potassium, sodium, bicarb, this combination is reflective of low aldosterone, okay? So this is Addisonian in picture. This is adrenal insufficiency. In this guy, he hasn't had recent infection like meningococcal septicemia. It's not Waterhouse-Friderichsen. I mean, if you had secondary adrenal insufficiency caused by a decreased ACTH from the anterior pituitary, that would only cause low cortisol. It's not going to cause low aldosterone. So this is a primary picture. The adrenal gland itself is fucked up. So zona glomerulosa not producing aldosterone. Eosinophils super fucking elevated at 25%. We say, what the fuck? Okay, so we'll just walk through the answer choices here. Next best step in diagnosis. We'll go backwards. Stool microscopy for ovarian parasites, wrong fucking answer. Now look, this is the factoid you need to know. In adrenal insufficiency, you can get eosinophilia. Super fucking weird, I know, I agree with you. It's not my opinion, okay? So apparently, as the literature has said, as I've found, is cortisol can play a role in causing eosinophil sequestration within the spleen. So in Addison disease, in primary adrenal insufficiency, your aldosterone is low and your cortisol is low. So low cortisol, theoretically, can cause eosinophilia, okay? It's on the 2CK exams. So just a factoid you have to be aware of. Stool culture, wrong fucking answer. I do not believe this is ever an answer in USMLE. I've never seen it as a correct answer, okay? And the reason for that is because stool antigen slash stool toxin test is correct for C. diff, C. difficile, okay? Not stool culture, all right? So stool antigen slash toxin, that's C. diff, could be H. pylori, but C. diff, super fucking high yield. Dexamethasone suppression test, this is wrong. This is for Cushing's syndrome, diagnosing the etiology. Long fucking discussion, okay? I could do a 20-minute presentation. It's to my observation, some students just never wrap their head around the dexamethasone suppression test. Most common cause of Cushing's is exogenous corticosteroids, prednisone. In that case, we would not do the dexamethasone suppression test. This is used to diagnose endogenous etiologies. Okay, if you give low-dose dex, it's a yes or no test. If a patient's cortisol does not go down with low-dose dex, yes, we have Cushing, but we don't know the cause. If it does go down, we do not have Cushing. If we give high-dose dex and cortisol goes down, diagnosis is ACTH secreting tumor of the anterior pituitary. That is called Cushing disease. Okay, Cushing disease, ACTH secreting tumor of the anterior pituitary. If it's not that one specific etiology, it's not called Cushing disease. It's called Cushing syndrome, which refers to anything. As I said, it could be a long discussion. If we do not get suppression of cortisol with high-dose dex, then we say is ACTH high. If it is, then we know that we have bronchogenic small cell carcinoma secreting ACTH. If ACTH is low, then we have primary zona fasciculata secretion of cortisol secreting adenoma or hyperplasia. Long fucking discussion. Anti-nuclear antibody, wrong fucking answer. This is pretty much never an answer for diagnosis, okay? It's very non-specific. It just reflects general autoimmune propensity, okay? It has sensitivity for SLE, meaning among autoimmune diseases, SLE tends to stand out, lupus tends to stand out as sensitive, where if ANA is negative, we can say not lupus. We can rule out lupus, okay? 95 to 99% of patients SLE will have a positive titer for ANA, but you can have autoimmune disease, not have a positive ANA. On USMLE, they will give you high ANA for any autoimmune disease. I have not seen any trick question where they have said a normal ANA for autoimmune disease, but you can see elevated ANA in patients without disease as well. Let's just keep moving on. ACTH correct. ACTH stimulation test correct answer. This is the diagnostic test for Addison disease, for adrenal insufficiency, okay? Cosine-tropin, synectin test, but they will write it as adrenal corticotropin hormone test, okay? So um, if we give exogenous ACTH to a patient who does not have adrenal insufficiency, we should see stimulation of the adrenal gland and an increase in cortisol levels. If a patient has adrenal insufficiency and you give ACTH, you shouldn't see an increase in cortisol. In real life, if you give ACTH to a patient who has exogenous ACTH to a patient with adrenal insufficiency, their cortisol will go up in truth, but very fucking modestly. Okay, like a very minor amount. Um, Whereas it should go up a robust amount. Okay, so that's why this is used to diagnose adrenal insufficiency. This could be a lengthy clip, but you need to take home. Eosinophilia can be seen in adrenal insufficiency. Fucking weird, but it's on the 2CK forms for USMLE. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe my channel. I appreciate your time. That's it.